Okay, so I want to talk to you guys for 15 minutes about things you may already know, and maybe some things you didn't. When we talk about the future of medicine and the development of new technologies, there's a mountain of information out there published about new tests, new policies, new procedures every day. It can be very difficult to navigate. So let me take you back a little bit as a flashback. Before my time in med school, before grad school, college, I was trained as an EMT. And first responders are instilled with this algorithmic thinking model, right? ABC, airway, breathing, circulation, for every patient, every time. So you don't have to fuddle around with that knowledge when you're trying to do some critical work. Let me give you an algorithm for today. I want to look at the tools with which, I want to look at tools in medicine. I want to look at the skills with which we use those tools. And I want to look at the strengths that make us good clinicians. So let's go on rounds. I think this is an excellent model. Those of us in clinical medicine know that when you go on rounds, you visit patients and cases one by one. You talk about what's been done, what's being done today, what needs to be done tomorrow, and then I will sign out to you so that you can take this knowledge with you back into your own practice. So let's start with those tools that I mentioned. The stethoscope, right? Clearly the most iconic symbol of a medical provider. Hangs around our neck. It's 200 years old, developed by a French physician in the 1800s. He was too modest to put his ear up to a woman's chest to listen to her heart. Good guy, right? It became a cone, and then it became a tube, and then no advancements happened for hundreds of years. Sure, we made them gold once upon a time because attendings needed to have them, and then we turned them into colors because heart sounds sound excellent with a red stethoscope, trust me. In the last couple of years, we put a spaceship on the front of it so you can record them and listen to them on your phone. Fantastic. Let's pause here for a second, though. There's a lot of medical students here, and when I talk about things like heart sounds, your hearts probably make sounds, right? So in order to memorize and learn and regurgitate things for exams, you have to sort of organize them into tables so you can process them. And things like sounds are very difficult to learn from a page of a textbook. So mine went something like this, right? You have systolic murmurs and diastolic murmurs. There's 4 heart posts: aortic, pulmonic, tricuspid, mitral. You've got some stenotic and some regurgitative, and some happen whole systolic, like a ventral septal defect. Some happen whole diastolically, like ASD. Some happen continuously, like a PDA. Then you've got ones that get better with squatting, ones that get better when you shake your fist, ones that get better when you squeeze your fist, but not hyperobstructive cardiomyopathy. But you have to know which ones are crescendo, decrescendo, and which ones have a click, and which ones are... It's exhausting. Thanks. Many med students today are forgoing this ancient piece of technology for a pocket ultrasound, right? It's a point-of-care ultrasound that fits in your lab coat pocket and gives you a new piece of information. Now, what do you think is more useful clinically? Doctor, I think I heard a whooshing sound before that first whoosh and that second whoosh. Will you listen for me? Or, doctor, this patient's got an ejection fraction of 35%, down 55% from last month, and I saw their mitral valve regurgitating in the diastolic phase. We should probably do something. That second student's getting that H in that class, I think. But that's example 1. Example 2 talks about a lot of conversations in medicine that surround themselves with antibiotic stewardship. The way we test for bacterial infection nowadays is messy and slow and sloppy. If you can get everything right without contaminating any step, it looks something like this. You draw a patient's blood, inoculate them into vials, bottles, or what have you. They go into an instrument. They get flagged for growth. A scientist cultures them onto media. They sit for a couple days in incubation. You isolate some colonies from that, do some biochemical tests, and in about a week, you've got a sensitivity report about what antibiotic to use. Well, your patient's probably on vancomycin already. The future of medicine and diagnostic microbiology might look like this. We've already got instruments that use genetic information to take a sample from a patient, a swab or a blood test, and using that genetic technology, IDs that bug and gives you a sensitivity in a day, turnaround time. Some doctors don't even put the order in for the antibiotic that fast. And we're getting this turnaround right away. This is going to change the way we talk about antibiotic stewardship. Now I want to go into pathology. The bread and butter of pathology is anatomic and clinical pathology, biopsies and lab tests, right? And the way we do this diagnostic workup looks like this today. Patients go in with a mass, some suspicious tumor, cancer. It gets taken out. Tissue gets sent to a pathologist who looks a lot like me with glasses at his desk, and reads it after doing some biochemical investigation. Sometimes it's done stat as a frozen section so that intraoperative report can go out the same day, but they still have investigations a couple days after. Again, it's slow. The future of diagnostic pathology might look like this. We've got new technology called liquid biopsy. We could just do a blood test and test for infinitesimally small amounts of cancer tumor cells that are circulating in your blood, or fragments of malignant DNA, or proteins that clue us into what's going on with that cancer. There's even new technology called in vivo microscopy, where it's actually being done right now in some lumpectomies for breast cancer or polypectomies in colonoscopies. Imagine your GI specialist doing a colonoscopy, fishing around in the colon for cash and polyps, and a pathologist alongside him can operate an attachment to that colonoscope where it puts a fiber optic microscope in that suspicious polyp and tells you what it is right there on the spot. No more waiting days for that turnaround. You've got clinical information right in front of you. It's going to revolutionize diagnostic medicine. New technologies I've even seen can measure your blood pressure from your facial capillaries by taking a picture, or do a drug test of a 12-drug screen with a fingerprint. The volume of publications and controlled trials grows exponentially every year, and in the last 30 years, exploded over 300%. But you can't talk about new technology without talking about artificial intelligence. Once upon a time, radiologists were really scared that we took away their films and we gave them computer screens. But it revolutionized the way that diagnostic radiology happens across large distances of space. Well, the same thing's happening in PATH with real-life tissue samples. We can look at a piece of tissue from a whole slide image and collaborate with colleagues very far away and do diagnostic workups in real time together that couldn't be done before with smart software. These are all great tools that are revolutionizing healthcare, but the skills with which we use them are very important. Otherwise, they would be for nothing. I went to a Star Talk recording a year ago with my wife, and Neil deGrasse Tyson talked about this really interesting concept in the history of academia, where specialists in their respective disciplines like biology and chemistry, astronomy and physics studied their disciplines. But then things got stale. No advancements were made. Until that guy in the biology office needed to talk to the woman in chemistry, or that physicist needed to talk to the astronomer, and you've got biochemistry and astrophysics and new disciplines forming with new technology and new skills. Well, that's the nature of medicine. In recent years, one of my favorite new things is space medicine. You can do a clerkship in this as a med student. You won't go to space, you go to Texas. An article I read even included an astropathologist story who was a veterinary pathologist working in space medicine, crossing over disciplines from internal medicine, infectious disease, and pathology. Fascinating stuff. The AAMC released the top 5 specialties that didn't exist a few years ago. Cancer immunologist, a nocturnist who only works at night on purpose. Clinical informaticists that use technology and computers to better patient care. Lifestyle medicine and medical virtualists who can see a stroke patient in their academic center in a hospital hundreds of miles away in an emergency room. We're seeing more patients, and we're seeing them better. In recent years, medical care has even improved to consider patients as a whole, the tapestry of a whole patient's story, their trauma history, their health history, their work-life balance, their stress balance, their interpersonal relationships, all contribute to the picture of what we call health, and we're getting better at doing it. But when we're seeing more patients, and we're seeing them better, and better outcomes are expected of us, our resilience is taxed. And when our resilience is taxed, we experience empathy fatigue and compassion fatigue and regular fatigue, except for that nocturnist who works at night. And we experience burnout. If you Google the history of the usage of the word burnout, it didn't exist before the 60s, but that was because of the space race. We had rocket thruster burnout. We wanted to beat the Russians. In the 80s, burnout came back, and in a big way, it exploded. Now, I was born then, so I understand, but it has nothing to do with me. It was about PCR, the Human Genome Project, the use of genetic information to redefine the way we talk and define diseases. If you look at the history of Nobel Prizes awarded in medicine and physics or physiology, they used to be for things like, hey, I found out what blood types are, or hey, I found this new cool thing called insulin. But now they're all about, this gene is for this disease, or I know how cells respond to a lack of oxygen. And that changes the whole conversation of medicine. So remember those 2 stethoscopes from earlier? What if I told you that they're different sizes? Raise your hand if you think the black one is bigger. What about the blue one? Okay, most of you think the blue one. Well, I lied to you. They're the same. I just moved it down a little bit. Why am I lying to you? Why are you doing this to me? We have a new role in medicine, and that's to be a champion of truth. And there's a lot of misinformation out there that we have to fight against, especially on the internet. We have to dispel myths, and we have to work with our colleagues to make sure that patients get appropriate care and appropriate information. Our weaknesses are also our strengths sometimes. Our passion for collaboration can silo us if we don't collaborate with the right people in the right frame. Our passion for patient care can lead to our own individual burnout, like I told you. Our dedication to data can blind us to things like racial bias or stereotypes in medicine that we've been practicing under as guidelines for too long, but aren't really true. Why am I torturing you with all this information? Well, if you got your degree in medicine in 1950, the depth and breadth of medical knowledge doubled in 50 years. It's pretty manageable. Over that course of 50 years, your career, you're going to have to know twice as many things. You've got some time to take a new board exam. But if you get your degree around 2020, the depth and breadth of medical knowledge is going to double in 73 days. I'm sorry, all the med students here. I'm sorry, but that's just the way it is. That chart of exponential research and growth is happening while you're sitting in this lecture hall. Knowledge is power, but that's ridiculous. You can't know everything every 73 days. There's no way you're going to be able to do it. So instead of just knowing things like those heart sounds, we have to learn to speak medicine so that new advancements in technology can change the way we interact with patients and our colleagues. Sometimes that includes thinking outside the box. You would have called me crazy if I said that we're talking to patients on social media nowadays, but we are. We have to. There are patients in disease forum boards on Facebook and Twitter message groups that talk about different experiences as patients navigate their own conditions. And they want physicians like us to come there and talk to them where they are, not come to their annual physical so that we could develop rapport. It's a lot easier to access them now on social media. But that comes with a caveat. A lot of technology now for patients visiting their physicians and clinics includes portal care. They sign their email up, and you get access to a portal where you can see your medical information, and you can look at your diagnoses, medications, and labs, but also so you can text your doctor at 1 a.m. But we have to respond. Now we're expected to respond. That used to be new and shiny, but now it's the standard of care. So you have to do this. When I need a prescription refilled, I just text my doctor. I don't make a new appointment. That's the way most people do things now. That's another piece of technology that we have to sort of just accept in our 73 days of relearning med school every time. We talked about the tools, right? We talked about all those new technological advancements. We talked about the skills that make those tools useful. Otherwise, it'd be for nothing. And we also talked about the strengths, things you already know that make us good clinicians, our empathy, our ability to collaborate, our dedication to our patient care. And the future of medicine is unrecognizable at this point. But don't let that scare you, because that's a good thing. You want the future of medicine to be unrecognizable because you're going into it. And if you're going into medicine when things are changing rapidly, then you can change them. The new test, that new policy, procedure, that new discipline, paradigm, the abandonment of thinking that eggs are good for you, or yolks are bad for you, or just the whites, or maybe the eggs a whole, or cholesterol. I don't know. It's going to change tomorrow. That's going to be you. The new drugs, the new ways to check blood pressure, the new disciplines of medicine, they're all going to come from people like you.